Hello, my name is Stephen Huang. I'm from Shriners Hospital for Children in Philadelphia. Today I'll be talking about the fundamentals of pediatric deformity surgery. As an outline, we're going to go over the definition of scoliosis today, as defined by the Scoliosis Research Society, and then talk about subtypes such as AIS, adolescent idiopathic scoliosis, congenital neuromuscular and syndromic scoliosis. And we'll go over the radiographic features of each, as well as clinical findings, and discuss what's relevant. Finally, we'll talk about each subtype and go more in depth, looking at the surgical indications and management of these. So the Scoliosis Research Society defines scoliosis itself as 10 degrees of curvature on the coronal X-ray of a patient. And so you measure end vertebrae to end vertebrae, such as delineated by these green lines. You get a Cobb angle, which in this case measures 82 degrees. The most common subtype we see is idiopathic, accounting for about 65% of children, and then less commonly neuromuscular, syndromic, and congenital. On exam, these children, we should always examine the back. So if they're standing and ambulatory, we'll have them stand upright, look at the shoulder height, and see if one side is higher than the other, especially if right is higher, if the left side's higher. Then often we'll have them do an Adams forward bend. So with the legs together, legs straight, we have them bend at the waist and lean forward as close as they can, hopefully 90 degrees at the waist. Then often you can take an inclinometer and measure the distance and the rotation across the rib prominence. Last, we'll look at the lumbar prominence, similarly just measuring the angulation formed by the rotation of the lumbar spine, and then look at the trunk shift. Look at the waist asymmetry from one side to the other caused by the scoliosis. We'll also look at the pelvic tilt in either seated patients or upright patients, make sure the pelvis is even, and then finally do abdominal reflexes as well as a normal full neurologic exam, looking at motor, sensory function, reflexes. Lastly, we want to make sure there's no leg length discrepancy, especially if the pelvis is elevated on one side versus the other. You can measure the ASIS down to the medial malleoli and make sure both leg lengths are equal. Finally, looking at the back, you want to make sure there's no cutaneous stigmata suggestive of spinal dysraphism, such as hypertrichosis, hemangiomas, or other abnormalities. And so in this red arrow delineates the rib prominence from a right thoracic curvature and the rotation of the rib cage elevating that right side. Here's a closer look at Adams forward bending images. The inclinometer is placed over the midline, and the elevation on one side gives you a numeric angular rotation of the asymmetry. This can be extended down caudally towards the lumbar spine to get lumbar prominence. The rib deformity, again, is attached to the spine, so as the spine rotates, the rib cage also rotates. There's an imperfect correlation with severity of rib rotation and curve magnitude. In this illustration on the right, you can get a general approximation that with a smaller curve there's less rotation, and more severe curves it's more significant. Next, for radiographic terminology, the most common used measurement is the Cobb angle. So the Cobb angle is delineated by the end vertebrae to the end vertebrae. So the most tilted vertebrae from the horizontal creates the top and the bottom of that curve. That angle is how we define scoliosis in two-dimensional planes. From the sagittal perspective, the plumb line is essentially a line drawn from the centroid of C7 and dropped vertically, and that distance from the posterior edge of the sacrum is considered positive when it's anterior and negative when it's posterior. Other measures that we use are the CSVL, the central sacral vertical line. So it's a mid-sacral line drawn vertically, and then from this we can measure distances, either the apex of the curve or the apex of the lumbar curve in the distance, or look at other caudal features of a scoliosis. So the stable vertebrae in this illustration on the right, SV, is delineated or defined as the vertebrae bisected by the CSVL. The neutral vertebrae, NV, is delineated by the vertebrae that is least rotated. So in this case, the pedicles are most symmetric with the vertebral body, and the end vertebrae we discussed previously. As we understand scoliosis better, the three-dimensional understanding of it has increased as well. So with EOS X-rays, we can kind of deconstruct the spine and get a better appreciation of its three-dimensionality. And we understand that we are actually underestimating the hypokyphosis or lordosis of the thoracic spine in this case. So a true lateral, or prior X-rays would estimate a lateral. The stagnera view X-ray actually gives us a better understanding of the true lateral, and then we're understanding with the 3D reconstructions, we're actually seeing a truly lordotic spine in these cases. Now, AIS, adolescent idiopathic scoliosis, is the most commonly encountered type of scoliosis we see. And again, all scoliosis is defined as greater than 10 degrees of coronal curvature. Children that are less than 3 years of age, or 0 to 3, often at the time of diagnosis, are defined as infantile scoliosis and usually have left-sided curves predominantly. Juvenile idiopathic scoliosis is when the onset and diagnosis of the scoliosis is from 4 to 10 years of age, and greater than 10 is considered adolescent, which is the most common subtype that we encounter. Most commonly, these children have right-sided curves as well. The prevalence of scoliosis is about 2 to 3% of the population, children. There's a slightly increased trend towards young girls, and then as the curve size increases, the incidence goes down. Only 0.2 to 0.3% of girls have a curve over 30 degrees, and predominantly women have those larger curves. It's unclear what causes scoliosis or adolescent idiopathic scoliosis. There appears to be some genetic predisposition and association, as 27% of daughters of women with scoliosis develop it as well, and it's much more common in monozygotic twins as well, but the actual genetic underlying etiology is still not clear. As we discussed previously, the age at diagnosis helps define the type. Infantile scoliosis predominantly is a left-sided curve with a slightly more even distribution of male and female, and many of these spontaneously improve and correct over time. Sometimes casting or bracing is required in young infants, but it can often also be curative, period. In juvenile, age of 4 to 9 years of age, has a slightly more female preponderance, but a large percentage of these curves progress over time. These children tend to be more skeletally mature, so have more growth, and that's been a common factor with curve progression. Adolescent curves, about 9 to 10 are female compared to each male patient with it, and often use the Linke classification to help define these, which replaced the older classification of the King-Mo. Early onset scoliosis has been an umbrella term to define scoliosis in younger children, just because there's a whole subset of issues balancing growth, lung development with curve progression, and typically children less than the age of 10 diagnosed with scoliosis fall under that category. The natural history of scoliosis is highly dependent on age and skeletal maturity. So younger children with a Risser 0 to 1 premenarchal have a much higher chance of progressing, especially if they present with a larger curve. In this case, Lonstein and Carlson wrote about how patients with Risser 0 to 1 who present with a 20 to 29 degree curve had a 68% chance of progressing, versus more skeletally mature patients who were Risser 2 to 4 and a smaller curve only had 1.6% chance. The Risser is a surrogate marker for maturity by measuring the ossification of the epiphysis of the iliac crest as it ossifies lateral to medial. There are issues with this as well, and it's been shown that the Risser is a little less accurate. Often centers use the Sanders hand X-ray now or other measures to try to get a better approximation. The initial management for most of these children are larger curves. So once curves reach 20 or 25 degrees, it's often bracing. And the primary reason for that is the brace trial that was published in 2013 showed about a 75% success with brace treatment compared to 42% who were not treated with a brace, period. The endpoint of success was defined as curves less than 50 degrees and not requiring surgery. So there was a 75% reduction in progression to surgery in those children. Further sub-analyses have shown that compliance with brace wear, so the more you wear the brace, does have an impact as well. And then those that progress through bracing or that present late may need surgery. Often, curves that are 50 degrees or larger are considered for surgical intervention, and it's primarily because of papers from Dr. Weinstein showing that curves that are 50 degrees, even at skeletal maturity, tend to progress on average 1 degree a year over decades of time. We really don't see clinical significant pulmonary compromise until curves are over 80 degrees in size, but cosmetic concerns can be quite prominent prior to this. Overall, the goals of surgery are to balance the spine, prevent progression, and to get the shoulders, the hips even and balanced. Ultimately, we try to achieve maximal cosmetic correction as well, and then fuse as few segments as we can to preserve as much motion as possible. Anterior surgery has decreased significantly since the advent of the pedicle screw. The main indications that still exist might be a Lanky 1 main thoracic curve or Lanky 5 thoracolumbar curve. These are occasionally still used. The primary benefit of an anterior surgery is it creates more kyphosis. So with a process such as adolescent idiopathic scoliosis, which is lordotic or hypokyphotic, you actually create more kyphosis with this. Some people still use anterior releases for large curves. And then for cases such as we discussed with thoracic hyperlordosis, this might be a primary indication. The Lanky classification was designed to help communicate and also to help define which curves to fuse. And so largely, the Lanky classification defines adolescent idiopathic curves into three categories or three criteria. You define what kind of a curve it is, so type is based on which curves are structural. And so looking at the Cobb angle and the measurements that have flexibility, you can decide the upper thoracic, main thoracic, and lumbar curves, which ones are structural, meaning the largest curve, and the ones that don't bend down or not flexible become structural. And those are the ones you ultimately want to fuse. The classification defines curves as 6 subtypes, and then looks at the lumbar modifier, the A, B, or C, depending on when that central sacral vertical line where it crosses the lumbar apex, and then the kyphosis component of the thoracic spine. And so in this example, the upper thoracic curve is measured from T3 to T5, the main thoracic from T6 to 12, and then thoracolumbar from... Hello, my name is Stephen Huang, and today I'm going to talk about the fundamentals of pediatric spinal deformity. So as an outline, we'll go over the Scoliosis Research Society definition of scoliosis, then talk about the 3 main categories, AIS, adolescent idiopathic scoliosis, as well as congenital and neuromuscular subtypes. We'll also go over radiographic findings, as well as clinical exam features of each of these patients, and then talk more detail of each of the subtypes and what the pathology, etiology, and surgical interventions entail. So the Scoliosis Research Society defines scoliosis as coronal curvature on x-rays of greater than 10 degrees. So in the radiograph on the right, if you measure the end vertebrae, which is the top and the bottom of this Cobb angle, measured on 82 degrees. The most common subtype we see is idiopathic scoliosis, accounting for about 65% of children, and then neuromuscular syndromic and congenital subtypes are a little less common. Whenever we examine a patient, aside from the routine history and physical exam, we also want to look at in ambulatory children, the shoulder height. So we want to have them stand upright, feet together, and see if the shoulders are even, if one side is higher than the other, and that helps us with our surgical intervention and our cosmetic goals, as well as look at the rib prominence and the lumbar prominence. We'll go over this in detail after. And look at the trunk shift. In this patient, she stands upright. There's an accentuated shift on the left waist list, and it's flattened on the right. We also want to look at the pelvis and make sure it's even, if one side is elevated versus the other. And if so, look at leg length discrepancy. Sometimes a leg length discrepancy can drive a lumbar curve. And you may measure this from the ASIS down to the medial malleoli and compare side to side. Usually less than 2 centimeters is acceptable and may be adjusted with a shoe lift, but greater than 2 centimeters discrepancy may need to be referred for a lower extremity surgeon. Also, a neurologic and complete neurologic exam is performed in these patients, including abdominal reflexes, to look for any asymmetry or abnormal findings. Lastly, we look at the back and make sure there's no cutaneous skin stigmata, such as hemangiomas, hypertrichosis, or anything that might suggest a spinal dysraphism. At the Adams forward bending, patients should stand with their feet together, legs straight, and bend at the waist forward, their arms down. In this case, you see the rotation of the right thoracic prominence elevated due to the rib cage attached to the spine. And so the scoliometer or inclinometer can be used to quantify this. It's essentially placed in the midline and brought up and down the spine, the thoracic area, and measuring the maximal rotation, and similarly repeated in the lumbar spine. The rib prominence is not directly correlated with the curvature, but there is a general correlation where with increasing curve and Cobb angle, there's increasing rotation of the vertebrae and increasing rib cage deformity, as seen in this illustration on the right. In terms of the basic radiographic features, as we mentioned, the Cobb angle is subtended by the end vertebrae. And so in the left image here, we measure a line for the end plate of the most tilted from the horizontal, above and below, and that creates the Cobb angle. In the sagittal plane, the plumb line is often used, so the centroid of C7 can be drawn and a line drop down from that, measuring that distance from the back of the sacrum. Typically, positive measurements denote an anterior shift and negative posteriorly. The CSVL is the central sacral vertical line, which is a line drawn up from the midpoint of the sacrum. The stable vertebrae is the vertebrae that's bisected by the CSVL, the SV in this image, and then the neutral vertebrae is a line, the vertebrae that is least rotated. So in this image, NV, where the pedicles are most evenly balanced in this picture. Scoliosis, as you mentioned, is basically 10 degrees of coronal curvature or greater. For adolescent idiopathic scoliosis, the most common subtype we see, at age of diagnosis, a further subdivision can be made based on the age of the child. So with idiopathic scoliosis, if the child is diagnosed less than 3 years of age, we call it infantile. If they're diagnosed from 4 to 10, they're juvenile, and greater than 10, adolescent. About 2 to 3% of children will have idiopathic scoliosis with a slightly female preponderance. The number of curves that progress beyond 30 degrees is much smaller. Only 0.2 to 0.3% of children have curves of that magnitude, and predominantly female as well. The etiology remains unclear, although there's a strong genetic link. About 27% of daughters in some studies of women with scoliosis also develop scoliosis, and then there's a much higher association among twins, but the exact genes have not been identified. Infantile scoliosis, infantile idiopathic scoliosis, so children less than 3 years of age at diagnosis often have a left-sided curve and have a more even distribution of male-female gender. Many of these may self-improve and self-resolve with observation, and occasionally may need casting or bracing for more severe cases, but can still be occasionally cured with aggressive casting. Juvenile idiopathic scoliosis, children that are 4 to 10 years of age when they're diagnosed, have a slightly greater female preponderance, but often have a higher rate of progression as they are young and skeletally immature. They have a higher risk of growth. Adolescent idiopathic scoliosis tend to be predominantly women and girls. And often the Lenke classification is used to help classify these and help with surgical planning. Early onset scoliosis is a term often used to define young children with scoliosis. So classically, children diagnosed less than 10 years of age with any type of scoliosis, also termed early onset scoliosis, as this carries a connotation and separate issues balancing growth, pulmonary development with risk of scoliosis progression. Idiopathic scoliosis often progresses or has the greatest risk of progression with skeletal immaturity. So young children that have a lot of growth have the greatest risk of progression. In the Lonstein and Carlson paper, patients that were RISR 0 to 1 with 20 to 29 30 degree curves at presentation had about a 68% chance of progressing, whereas more skeletally mature patients, such as RISR 2 to 4, with smaller curves had a less chance. The RISR is a radiographic feature looking at the ossification of the epiphysis of the iliac crest. This tends to ossify from lateral to medial. There's a grading system on the right showing how the epiphysis is broken down to quarters, and as that is ossified, it gradually becomes more white on an X-ray. There are studies showing that the RISR is a little less reliable and has a broader predictive range, and so the Sanders hand X-ray often is a little more accurate in predicting what phase of growth children are and the risk of progression. Once patients are identified with scoliosis, often the initial management is bracing. We know from the Brace trial published in 2013, where patients were prospectively observed and treated, that there's a 75% reduction or progression to surgery or curves greater than 50 degrees. And so this study was stopped early because the results were so convincing. And so typically when curves reach 20 to 25 degrees, a brace is prescribed. There are lots of different types of braces, and those have been compared to different capacities. But ultimately, the more they wear a brace, the more effective it is. Often when curves fail bracing or are identified later, they may require surgical intervention. So when curves are greater than 50 degrees in magnitude, often surgery is indicated. A lot of this stems from the earlier Weinstein paper showing that curves that are 50 degrees or larger, even at skeletal maturity, tend to progress 1 degree a year over decades. Often clinical significant cardiopulmonary compromise is not seen until curves are over 80 degrees in size. And overall, the goals of surgery are to balance the shoulders, the pelvis, the hips, reduce the curve size, and prevent progression. A well-balanced, cosmetically improved curve is the goal. Ideally, we want to preserve as many motion segments in the lumbar spine as possible to prevent degenerative changes and maintain function. For adolescent idiopathic scoliosis, the Lenke classification is the defining way to classify it. Overall, the Lenke classification takes idiopathic AIS and subdivides into 6 types based on structural and non-structural curves. The underlying premise is that curves that are structural should be considered for fusion. Ultimately, the largest curve is always considered structural, and then curves that basically don't bend down less than 25 degrees or have excessive kyphosis are also considered structural. And so the Lenke classification has 3 main factors. The initial curve type, so Lenke 1 to 6 based on which curves are structural. When we look at a spine x-ray, we should divide the spine into upper thoracic, so T2 to T5, main thoracic, T5 to T12, and then lumbar, L1 to L5. And looking at these curves, we'd see which ones are structural based on those criteria of largest curve and flexibility, and then decide which curve type it falls under, 1, 2, 3, 4, 5, or 6. Then the second criteria is the central sacral line. So from the CSVLL line is drawn, and looking at the lumbar apex of the curve, we see if the line falls within the pedicles, between the pedicle and the lateral aspect of the body, or lateral to the body, which would be A, B, or C respectively. Finally, we look at the thoracic sagittal plane and look to see if it's negative, lordotic, neutral, 10 to 40 degrees of kyphosis, or greater than 40 degrees of kyphosis, hyperkyphotic. Based on these, we get an overall classification. In this case, on the right, an image of a Lenke 5 curve where the lumbar curve is structural, and presumably the main thoracic curve, which measures 40 degrees here, is flexible and bends down less than 25 degrees, making the only structural curve in this case the lumbar curve. So it's a Lenke 5C, as the CSVL is lateral to the pedicle. And then presumably a neutral thoracic kyphosis. So in this curve would be a 5CN. Overall, the Lenke classification helps us communicate and discuss standardized communication of curve types and give us a guideline about when and which curves to fuse. Overall, there's significant controversy about which segments to fuse. As in general guidelines, for selective thoracic fusion, where you just fuse a thoracic spine and leave a lumbar curve alone, that can be considered and should be considered when there's a lumbar Lenke A or B modifier. Ultimately, we want to correct the thoracic spine and balance it with the lumbar spine. More controversy exists when you're looking at a C modifier and this significant coronal translation of the lumbar apex. Generally, you try to fuse and stop at L3, but significant variables come into play, and a constant debate is L3 or L4 in these patients. Often the rostral extent of fusion can also be debated. As a general rule of thumb, if the left shoulder is elevated, extending up to T2 may give you more control and help you balance the shoulders. If the shoulders are even, stopping at T3 may be reasonable. And if the right side is elevated for a right thoracic curve, stopping at T4 is reasonable, as correction of that thoracic curve will drive up the left shoulder. In terms of lower level selection, for selective fusion, significant variables have been previously reported. The CSVL historically has been used, and the stable described by the stable vertebrae by Harrington. However, significant variations have subsequently been published looking at the stable vertebrae in relation to invertebrae and neutral vertebrae and this distance from either. A safe guideline is to look at the last substantially touched vertebrae, so the last caudal vertebrae that's significantly touched, or the pedicle is at least touched, by the CSVL, and consider using that. For congenital scoliosis, this essentially defines abnormal formation of the vertebrae. Often this happens in utero during pregnancy, and can be often associated with kidney, heart, or spinal cord abnormalities. So the general workup for these patients includes a renal ultrasound, a cardiac evaluation, and an MRI of the entire spine at some point. In this child, there's a right thoracic curve with an extra hemivertebrae accentuated by the orange circle at L1 on the right. Often, embryologically, these are formed by failure of segmentation, where their vertebrae fuse and don't segment and separate properly. Failure of formation, where there's a hemivertebrae on one side, but not a counterpart on the contralateral side, or mixed malformations, where these are amalgamation of different factors. Usually it occurs during the 5th to 8th week of gestation and occurs about 1 in 10,000 of newborns. Dr. McMaster illustrated and described different examples on the right. These highlight some of the more common seen etiologies. Occasionally these can be associated with rib abnormalities as well, and should be identified as this can affect pulmonary function. Dr. McMaster looked at the progression risk, and ultimately different features were associated with different risks of progression, where ultimately the highest risk of progression was associated with curves in the thoracolumbar spine that had hemivertebrae on one side and a bar on the other side. In essence, you can think it's anchored and tethered on one side with 2 growth plates on the contralateral side, allowing for the greatest asymmetry. Some of the difficulties with congenital scoliosis is that the old adage of short and straight is better than long and curved has now been replaced. Historically, physicians thought a longer curved spine was worse than having a short and straight one, but that ultimately led to increasing pulmonary difficulty with failure of the lung capacity to develop and cosmetic concern, where the torso was short and the arms were significantly longer. Thoracic insufficiency syndrome can be associated with these patients as well in multiple various forms. Dr. Campbell has published and classified all the different kind of rib abnormalities that can be associated with this, and different theories have been proposed to try to address this. There are radiographic features that can infer lung development. So the space available for lungs is a radiographic feature that may infer the lung function. The thumb excursion test is a physical exam where you can place your hands on the chest and with inspiration, expiration measure the distance and spread. But ultimately, pulmonary function tests are the best way to assess this. Congenital scoliosis patients do have impaired pulmonary function. Several papers have looked at their pulmonary function compared to age-matched cohorts and found that thoracic lung capacity as well as FVC and FEV1 are decreased, even post-treatment. There's several studies showing that early fusion also leads to worse pulmonary function. So fusion of more segments or even extending to T1 and T2 may be associated with worse pulmonary function. Dr. Carroll looked at it and found that ideally, as an indirect surrogate marker, T1 to T12 height of 22 centimeters is ideal. And any fusions that prohibit this or prevent this have more deleterious impact on pulmonary function. In order to try to address this, different growing systems have been devised. So the initial growing rod, were spine fixation or rib to spine fixation and distraction posteriorly that allowed for growth. The newer iteration of this is the magic rod, the magnetic expandable device that allows expansion magnetically through a device without reoperation. This is still in its infancy, and so we're still learning about that. The Vector, or vertical expandable prosthetic titanium rib, was designed by Dr. Campbell to help with lung capacity, with the idea that it was rib fixation to spine or pelvis, and similarly could be distracted every 3 to 6 months, allowing for lung development. Ultimately, they all have limitations and issues, and further research is going on to find better ways to address the problems in early onset scoliosis. Some of the potential benefits and limitations with growing rods and even magic rods, the benefits that allows continued growth and corrects some degree, usually 50 to 60% of the curve size. However, the main downsides, it does not address any rib fusion. Often patients develop autofusion after a certain amount of expansion and may limit your improvement at some point. They're also associated with a relatively high complication rate from dislodgement, reoperation, breakage, or infection. The Vector device has similar benefits and complications. It may be used to treat fused ribs and allow for greater rib expansion, allow for pulmonary development, and also improve the curve in a similar magnitude to traditional growing rods. However, it has limitations of autofusion along the device or along the ribs, and a similar complication profile to traditional growing rods. Ultimately, early onset scoliosis is still a very complicated problem with a high associated risk. Further effort is ongoing into designing better tools and techniques to help address this. Neuromuscular scoliosis is another large category that we see in patients, most commonly with the diagnosis of cerebral palsy, but it may include things as spinal cord injury, myelomeningocele, and subtypes of syndromic scoliosis. The SRS, the Scoliosis Research Society, defines it in either subcategories of primary neuropathy, including upper motor neuron, lower motor neuron, or combined, or primary myopathies. The incidence varies, but can be anywhere from 20 to 70% in patients with cerebral palsy. Often, the lower the function or the more poor the function, the higher the risk of developing. Often quadriplegic patients have a higher risk of developing scoliosis. Similarly, spinal cord injury patients that are immature skeletally and younger with a higher level of injury have a higher rate of developing scoliosis. Patients with myelomeningocele also similarly, based on the functional level, so higher thoracic myelomeningocele, and younger patients tend to have a greater risk of developing scoliosis. Overall, these patients often have a long C-shaped curve with pelvic obliquity, often in relation to muscle imbalance or weakness. It can be created iatrogenially after a laminectomy for tumor or decompression, and many of these patients are wheelchair-bound or non-ambulatory. Significant issues with the deformity are that patients develop pelvic obliquity and may have asymmetry sitting, leading to sores or skin breakdown issues. In some cases, the curvature is so significant the rib cage pushes into the abdominal cavity, causing GI issues or feeding issues. And some patients may have pain or have trouble sitting or transferring, and in severe cases may have cardiopulmonary compromise. The red line here illustrates the pelvic obliquity in this patient, as well as a coronal translation. Indications for surgery often in these patients are curves that are greater than 50 degrees, although typically patients are probably at 70, 80 degrees by the time they have intervention. The goals of surgery are typically to level the pelvis so that patients can sit better, to level the shoulders so that they're balanced, and then overall prevention of progression of the curve. These patients have a higher risk of complications surgically, probably in relation to their overall health and medical status, and surgical consideration should be weighed carefully in these patients. Thank you for your attention.